All right, thank you for staying with us. The conversation is about health, wellness, of course, as they say, health is wealth, and to keep us stronger, healthy body, healthy mind. Because when all these things are in place, that's when you can give your career a shot. That's when you can get out of your house and go achieve and conquer the world. But if you don't take care of yourself and your health is impeded, you might find it difficult to achieve some of those things. So that will not be the way they say it in Nigeria, our portion. We're talking about these issues today, and our focus is on health. And yesterday, November 14, it's the annual World Diabetes Day, and is an international, day observed. And the theme for this year, 2024, is breaking barriers and bridging gaps. Breaking barriers and bridging gaps. When you hear that, you might think it's one of these motivational talk, but it's beyond that. And then we have with us today a professional, top one, to look into this matter. She is a consultant, physician, and endocrinologist, Dr. Adepimpe Yusuf, and a brief about her. She is, just like I said, an endocrinologist at the Ocean State University and teaching hospital as well, where she specializes in research on diabetes mellitus, thyroid disorders, and obesity. She has written a chapter in Cushing's disease in medical textbook titled Companion to Tropical Medicine, and a chapter on HIV and diabetes in another textbook titled New Insight into HIV/AIDS for Students and Healthcare Professionals. And she's here with us. Good morning, Mother.
Good morning.
Thank you for being here again.
Thank you for
This
having
same
me.
time last year, we had you
Yeah.
to talk about this matter, and we appreciate your coming, actually.
Thank you
Thank you
very
very
much.
much. Yesterday, November 14, is the annual international day set aside to look into issues around diabetes. And the theme for this year is breaking barriers, bridging gaps. Why do you think we are having that theme at this time, talking about diabetes?
Okay, thank you very much. We have that theme as WHO
Right.
and some other bodies, and there's another theme
Mm.
as is diabetes and well-being.
Okay.
So both of them, they are targeting the fact that we need to reach our people, we need to prevent development of diabetes, and those that have been diagnosed, we need to take good care of them. Bridging gaps, breaking barriers.
Mm.
You want to bridge the gap of access to care, then reaching the unreached, reaching the yet to be diagnosed people. Now we have more than 500,000,000 people living with diabetes globally.
500,000,000.
Yes. So this 500,000,000, it means that we have another 500,000,000 that are yet to be diagnosed. We want to go by the rule of half. That means for every patient that has been diagnosed, there's one in the community
That doesn't know.
that has not been diagnosed or that doesn't know his or her status. So we are bridging the gaps and breaking the barriers. We are trying to reach them to get them diagnosed. We are trying to reach the diagnosed to have them have access to quality care. And those that are being cared for, we want to treat them to target so that complications that can take life eventually are prevented. So that can be summarized. And then for the under the breaking barriers and bridging gap. The other theme by the IDF, International Diabetes Federation, is diabetes and well-being. We want to look at them in totality. For someone that has diabetes, does the person enjoy whole health, in quotes? We're talking about physical fitness. The person is physically okay. The person is mentally okay. And then talking about the society, are they accepted? Are they approved? Are they well taken care of in their places of work? Are they stigmatized? So we want to look at all of this so that we can deliver awesome care to our clients.
Right.
Thank you.
And quickly, so that we start with the right context. When we talk about diabetes, for many persons, they are aware. For many persons, they are having information that are not totally the truth. And so you are here, you are a consultant, you are in the business. When we talk about diabetes, what are we talking about?
Yeah, we're talking about a disease that involves the way our body handles the food that we eat. So it's a metabolic disorder that involves carbohydrate, protein, and fat metabolism. And then it manifests with high blood sugar that we call hyperglycemia. And then this hyperglycemia results from inability of the body to be able to utilize the glucose that has been taken due to relative or absolute insulin deficiency.
Insulin
So deficiency. May be there, and the body may not be sensitive to it, which is the type that we have, which is what occurs in people with type 2 DM, but it may not be there at all. That is absolute deficiency, and that is what we have in type 1 diabetes mellitus. We have other types, gestational diabetes mellitus, and the one that we group as others. Others are those other
Let's
types
quickly look into all of that as well.
So those are, we have a whole lost under that one. It may result from every one of those things has to do with the pancreas. When the pancreas is diseased, and the cyst can occur, the pancreas can become diseased from different factors or for different reasons. There may be infiltration of the pancreas. We have pancreatic cancer. So when there's infiltration into the normal pancreatic tissue, the pancreas will not be able to deliver the normal physiological function. And so the beta cells that secrete insulin will also be affected. And once there's insufficient insulin in the system, it will manifest as diabetes. Then there may be inflammation. Maybe the person has ingested something that the body is reacting to, or it may be in form of food, it may be in form of maybe additives to the food, it may be from infection. It will also affect the pancreatic tissue, and it will manifest as diabetes. We have some other people that have issues in their DNA, their genetic makeup. Apart from the type 2 DNA, we have some other disorders that affects the DNA of those people, and this results in inadequate function of the pancreas. So all of this will result. There are some other one, infiltration. Some other people might have had chronic pancreatitis, chronic inflammation or swelling of the thyroid gland, pancreas, while growing up. And so after some time, it may also come down with that. But the other ones that are popular are the type 1, type 2, and then the gestational diabetes mellitus.
Which of these types is more prevalent in our climate here?
It is type 2 diabetes. If you have 100 patients with diabetes, like 90 of them will have type 2. That is the one that is the most prevalent all over.
So I'd like to speak to research and advancement. Like we had here last year, and we were able to cover, some topics on this particular issue on diabetes. I'd like to know if we have some latest advancement on diabetes research and treatment within the space of last year till this year.
Until this year. Well, I would say much has been done concerning this aspect, but the problem we have at this end is many people cannot afford it. We see
afford
the treatment.
Okay.
There are researches into, even some people are thinking about working on the pancreas itself.
Exactly. Yeah.
And then finding a way to bring it out to function better. And there are drugs that have been worked on, like we call some DPP. I don't want to be mentioning big names now, but insulin. There's some things in the body that after it has worked for a while, after the body has secreted it, there are some other hormones that are secreted from the intestine that goes to work synergistically. That is in addition to support continuous production of insulin, so that it works for a longer time to be able to take care of this. We call those ones incretin mimetics. And so in those categories, you have what we call DPP4 inhibitors, but these drugs are very costly. Some people are working on the present insulin that we have now. Most of them, all of them are injectables. and some of them are working, some people are working on additional insulin. That's all those pricks. Because before you administer insulin, you need to check what is happening, what is the level of the blood sugar before it is administered. So that patient doesn't give a dose that would tip the individual to hypoglycemia. So that means for every injection of insulin, the patient will receive 2 pricks.
Yeah, for checking and for
administering. Except for when they are giving basal insulin.
Okay.
So the basal insulin may not necessarily warrant pricking. So how do we avoid all these pricks? So some people are working on inhalational insulin, and it will be like what the asthmatic people use, like inhalers.
Yeah.
So that one doesn't, well, maybe they will just need to check the sugar and then inhale the insulin. And then these checks too, there are some people that have worked on continuous glucose monitoring, in which a device is applied to the body, and then there's a sensor that reads the glucose level. So it gives like a continuous picture of what is happening. And
the
with
device
that device,
is inserted
into the skin.
Okay.
So with that device, it's been so programmed that once the glucose level goes beyond a certain level, there's injection of insulin into the system. So that is another way in which
that's available now. Is it available now?
Available,
or it's still in the works?
It's available, but I'm not. I'm not so sure whether we have.
Permit me to butt in here, because many persons watching, hearing insulin, hearing some of these things might be thinking, what are we talking about? I think we're already getting to the treatment level. But before that, let's talk about the symptoms. Then we'll do this. Talk about the prevalence. And is there a reason, you've spoken about DNA and some of those things, is there a reason why the type 2 is so prevalent? Is it a lifestyle thing? Is it just the way it is? Is it science?
Well, it is.
And then we'll go to the symptoms.
It's genetic predisposition. Most people, type 2 diabetes runs in families. So they are genetically, would I say programmed? So let me
so
not
it
say
could be
programmed.
hereditary?
Yes,
is that what you're saying?
It is.
Okay.
Because they have some deficiency in their makeup that
Wow.
predisposes them to inability to handle glucose very well. So, and then lifestyle may further potentiate this tendency. So for somebody that has type 2 diabetes, if healthy lifestyle is adopted, the individual may not come down with diabetes. But if the person doesn't really watch the food they eat, their lifestyle, because of that tendency, that predisposition, they can eventually come down with it. So because it runs in family, I think that is why it is more common when you compare it to the other types. And then for the symptoms manifest. Well, let me first say that it may first appear symptomless. That is what we call asymptomatic. The individual may not be aware at all for several years before it begins to manifest. So, and
is
that
why
is
it's called the silent killer?
It is. You can go for silent killer. So also the hypertension.
Right.
Can also go for that. So it is asymptomatic, and then by the time it's presenting, by the time it's manifesting, the individual will start experiencing passing excessive amount of urine, large volume. There's a difference between going to the toilet to urinate every now and then that may be due to infection or some other reasons. But for somebody that has diabetes, each time the person goes to the toilet, the person urinates a large volume of urine. So, and then as fluid is leaving the body, the thirst center will be stimulated and the person will be feeling thirsty. The body will be telling that individual there's need to replace this fluid that is being lost. So it will manifest with passage of large volume of urine, excessive thirst. And then the urine that is going out excessively is going out with glucose. You can say that it is glucose that is actually drawing water along with it out. So instead of the individual making use of the food ingested for the health of the tissues, this glucose is being wasted via the urine, and it will eventually lead to weight loss. So you can say excessive urine, excessive thirst, then weight loss. And then some people will start to eat. As they are losing weight, they want to replace what they are losing. So some people will add excessive eating to it. But clinically speaking, once we hear about polydipsia, which is excessive amount of urine and thirst, and then weight loss, we want to think about diabetes. Some other people may not present with these classic symptoms. They may present with complications of the disease, and it may manifest as inability to see very well, blurry vision. They're not seeing well, images are becoming blurred. It may manifest like that, and then they go to see the ophthalmologist, the people that take care of the eyes, and then they check their sugar, and then they see that it's high up there. And that is when we get them referred to us. Some other people may present with delayed wound healing, and some people may misinterpret it for maybe like some issue that cannot be explained, that this wound that is not being healed, until they get somebody to tell them that why not check your sugar, and that is when they will know for the first time that yes, diabetes is the cause.
Like they have a cut or a wound, and the thing will not just go away.
It will go away. It usually occurs in the feet. So maybe due to trauma or accidental, maybe the person had a fall, or the person had a fall, road traffic accident, home accident, and stuff like that. Some other people may be having recurrent boils. Some people may have what we call tinea pedis, some whitish infection in between the toes of the feet. And then those whitish infection will begin to degenerate, and then will begin to eat deeper into the tissues. So that way they develop a wound that may not heal. Some people may have maybe hot substance poured on them. So some people may be on bike, maybe their leg accidentally touched the
silencer.
The silencer. So we have all kinds of reasons for them coming down with that. So we may pick them for the first time with complications. And that is why we encourage people anytime they have the opportunity to try check their blood sugar.
How often should one check their blood sugar? I mean, people that have not been diagnosed yet.
Those have not been, once a year should be okay, or twice.
Twice a year.
A year. So, but once somebody is aging, if it doesn't run in the family, because type 2 tends to manifest, though we're seeing it in teenagers now too, but as people advance in age, that is when it becomes more visible. So we can say once a year or twice. For those that have family members, if they do it up to 3 times, there's nothing bad in that. So just to be sure that it is picked early, and then there's what we call pre-diabetes. That is in between diabetes and then the normal range. So there's a gap, there's a range in between that. That if an individual is picked, lifestyle adjustment can be instituted early, and that person can be reversed to the normal range. So they will not cross.
But once you cross, once you are diabetic,
once
and
the
you've
person
been diagnosed, there's
yes,
nothing that can be done again.
Yeah, there is. Only that the person now has diabetes. The person now has the person has been diagnosed. But you can work on that individual, bring back to the pre-diabetic range, and then to normal.
So it's possible for someone that has been diagnosed with diabetic to go back to the normal range?
Yes. That is why they come to see us in the hospital.
Okay.
We want to bring them to now because
many persons believe it can only be managed.
Yeah.
Once you have it, you have it.
Yes. That person, we should not make, I'm not saying the individual can be cured.
Okay.
And that's why I said,
that's the point we are making. Can
yes,
it be cured completely?
It cannot be cured. It can only be managed.
Okay.
But it can bring the person from the value of abnormality to normal. But we still have it in the background that this person has diabetes. Only that now it is controlled. So we use the word controlled.
If it's controlled, can that person live a normal life?
Yes.
Quote unquote normal life.
Exactly. Without complications. And that's what we are striving for. Because once you get the glucose within the limits of normal, the damages that are done because of high blood sugar glucose level will be minimized or even eliminated if the patient can be maintained within the normal range. So we'll say that, okay, because of the way they handle fat, protein, and every other thing, they may eventually develop complications. But if they will still develop the complications, they will be pushed further into old age. So if they are going to come down with complications at all, let it be far into the future.
Okay.
Not seeing complication as early as the age of 30, 40, 50, 60. No.
Dr. Yusuf, does this diabetes thing does it have anything to do with our gender
Well, from
or our
statistics,
race as black people?
yes. Yes, it's commoner in blacks, it's commoner in females.
Mm.
So it has something
Why?
to do with this.
I'd rather ask as well. Why?
Well, let me say
Is
everything
it a
will still go
genetic
back.
thing or a
Yes.
lifestyle thing?
Yes. So everything still go back to genetic predisposition. Because when you're saying, okay, this race, they have it more, yes, then lifestyle thing can also be there. Diabetes is a multifactorial thing, but there's that genetic tendency. We have, when we are talking about, especially the commonest one, type 2 diabetes, you're talking about the modifiable and the non-modifiable risk factors. The modifiable, the non-modifiable, there's nothing we can do about it. And that's when we talk about genetic predisposition, family history. Once it runs in family, in that particular family, there's nothing we can do about it. Then in females, it's been found to be commoner.
Why?
We have what we call gestational diabetes mellitus,
Okay.
in which patients can develop resistance to insulin. They have, let me say, if they're developing it first in pregnancy, they have sufficient insulin in the system, but it's only that the body is not sensitive to it because of pregnancy hormone. And these hormones of pregnancy becomes more established around the 5th month of pregnancy. And that is why they hone down on that particular time to make sure that it's not as if they will not be checked before that time for glucose, but they also want to pay particular attention to that time because this is when body secretes more of this pregnancy hormone that can interfere with sensitivity to insulin. And so these patients with GDM, they stand the risk of coming down with type 2 diabetes later in life, together with their offspring.
Together with their offspring.
Together with their offspring. But if they are well educated right from the beginning, then they adopt lifestyle. This lifestyle we're talking about is eating a healthy diet.
I think we should go there. Let's speak about the lifestyle. How do we predispose ourselves to eat? And this lifestyle that you're talking about, what exactly does it mean? So that our people, because the purpose of this program this morning, first for information and then for education.
Okay. So lifestyle, when we talk about lifestyle adjustment or lifestyle modification, we're talking, it can be broken down into two, which is exercise and diet. For exercise, it's been prescribed that we do an exercise that will last for 30 minutes for 5 days in a week. That is about 150 minutes of exercise broken into 30 for 5 days. So if you do that, that will help us to keep fit and then to prevent people from going beyond the normal BMI. And so we have overweight, we have obese. Once we stay within the normal BMI, there will not be fat accumulation in the body and it's healthy. Insulin does not work very well where we have too much fatty acid running. So, but if the fats, we call it lipids in medicine actually, if they are in adequate quantity, then all of these hormones will be able to work within the normal physiological limits. So when we exercise, there's tendency for us to burn any kind of stuff. You know, when we eat more than we need to use, the excess will be stored as fat. But when we engage in a lifestyle of activity, that we are not living a life of redundancy or sitting down for so long, then we are able to maintain good physical fitness that will help these hormones to function optimally. So in this day of remote for television, for fan, for this and for all of that, we intentionally make sure that we observe this 30 minutes of exercise. And then for those that have some kind of ill health, they may need the advice of their doctors on the kind of exercise that they need to do. So I'm not saying that we just climb the treadmill and start exercising. There may be background disease that may get worsened because of that. But we can still take a walk around the house and all of that. So number 2 is diet. Now the kind of, say maybe what we are engaged with this day, everything is fast. So you need to do this, you need to get this done, get this assignment submitted, look into this, sort out this.
Right.
So there's tendency for us to want to fall back on fast food. You just eat on the go, eat on the go. And then foods that are fast, they are not all that healthy, because most of them are made up of fat, carbohydrates, they are loaded with sugar. So by the time we take it, we get the energy to move on. And so we advocate that we take more of natural food. Because when we take food that are refined, also drinks that are loaded with sugar, that are loaded with high level of calories and sugar, it gives us instant energy that we need to do whatever task we are trying to accomplish. So, and that one doesn't help the pancreas, because it goes into the bloodstream immediately, and then the pancreas is struggling to meet up with the glucose excursion that has happened. And so we are tasking the pancreas unnecessarily. But if you eat natural food, the body will break it down. It will go into the system. It will follow a kind of process that the pancreas will be able to catch up with and remove, because the agents are natural. So drinks also, the same thing goes for them. They go straight into the bloodstream and all of this. And then they are loaded with too much of this thing that we eventually don't end up using. And so it gets stored as fat. Then apart from that, they are not soothing, they are not satisfying. So when we take this fast food, there's still longing that I've not eaten, I've only taken snacks, I've only taken this one to just calm me down. I need to take proper food. So we've loaded ourselves with a lot of sugar already, and then on top of that, we now eat what we consider as now the natural normal food to satisfy the satiety that we have, because the stomach has not been filled up with that. So all of those will lead to us gaining weight with time. So how do we do then? The way we process some foods, we also relate them like some food that we should eat, boil, maybe fish, meat that should be boiled and taken, or fry, all of them. And fat carries a high percentage of carbohydrates. So when we fry our foods, some people will fry yam, they'll fry fish, they'll fry meat, anything can be fried, plantain, all of them. And so we ingest all of this, it will eventually lead to fat accumulation, and then it will hinder insulin sensitivity. So in the management of diabetes, these are the first things that we mentioned: exercise and diet. If they are able to observe these first two things, then number 3 is pharmacological agents, which comes as medications. If they're able to observe the first two, they will experience some drop in their glucose level. And then the drugs that will be added to it will not be that many, because of what they are doing. And by the time they are incorporated, they are doing that one, we are giving medication and they are observing the first two. Yeah, with time, one can begin to tail off the medications, because now they are maintaining healthy lifestyle. So they may not need as many drugs as you might have written before. If you put them on 2-3 agents, you might need to drop one, then drop another one, keep them on one. So that is why lifestyle is key. And then I want to say that even not only for patients with diabetes, all of us, because I mentioned initially that the situation in which we find ourselves, everything is fast. So all of us are trying to cope. So it should be extended to the rest of the population too, because we have hypertension also on the increase, increased salt intake and all of this. And we say diabetes and hypertension, they are sister diseases. So we are loading ourselves with salt too, preservatives and all of that. So healthy lifestyle, even choosing the food that we eat, will help us, go a long way in helping us to maintain good health.
Yeah. In other words, you're saying, as far as diet is concerned, we should go as natural as we can.
Yeah.
Exactly. Okay. Now, you talked about getting ourselves tested at least maybe twice a year. Must one always get to the hospital before you are tested, or are there ways we can test ourselves at home or check this thing at all?
Yes, it's possible, because we have small meters that can be used. But not all these meters are accurate.
So would they be as accurate as what of things in the hospital?
Yes, so not all of them are accurate. So if we get one and then you get tested, it's still essential. It's important to get to the hospital for confirmation. And if one, maybe it's out of range for the first time, that doesn't mean that person now has diabetes. No.
Okay.
Especially in the absence of symptoms. You said it can be symptomatic and then you can have symptoms. But if one gets tested and it is high and there are no symptoms, that individual will have to test again and even probably test it the third time before we finalize that, okay, this person has diabetes.
So,
but if in the presence of symptoms that I have mentioned, excessive amount of urine, excessive thirst, weight loss, tiredness, fatigue, and all of that, and the sugar is high, then the diagnosis is made.
All right. I'd like to speak to diet because there are some people, especially diabetes patients, that believe that as a diabetic, they have to eat mostly bitter food. You know, they tell you if you don't go near anything sweet, if it's bitter and veggies, you know, they say, oh, take more of maybe bitter cola, take more of, some people even go for herbs, you know, natural herbs. They say, so far it's bitter, it works for it. They believe bitterness is the antidote or the cure
sweetness
to that, because they believe diabetes has to do with sweetness, you know, sugar. So, you know, this all. So I'd like you to speak to that. Bitter foods, you know, bitter cola, bitter herbs, and also some, you know, maybe bitter leaves. Those are some of the foods these people eat because they believe it works for it. Is that true?
Well, we have facts and myths about diabetes. So what you've just said is, well, something is too sweet, let's take bitter thing to counter it. No.
Okay.
No. Though people are working on herbs. But what I just want to talk about is, if these things are natural, then they may not be counterproductive.
Okay.
But they do not take the place of proper medication
for
diabetes mellitus. So taking bitter cola,
bitter
leaves cannot cure diabetes or treat it. But bitter leaves is one of the vegetables. So it can be mixed with other vegetables and taken. Not that they go solely on bitter leaf in the morning, bitter cola in the afternoon, and another bitter thing in the evening to take away the sweetness. No, because of the way, the mechanism of this problem, the problem itself, the way, I don't know, the chemistry of the whole problem doesn't match the way these things work in the body. So the answer to that is no.
All right. There are some people that also believe that diabetes, people that are diabetic are prone to being skinny. In fact, when you drop, probably you were chubby person before, and all of a sudden, maybe the person has seen you for a long time, maybe 6 months or 1 year, and the person sees you skinny, like, are you diabetic? They believe that once you've dropped to that, you know, being skinny or thin, they believe it has to do with diabetes. Now, there are concerns from people who are diabetics who probably are skinny and they want to gain back some flesh. They believe I'm too skinny, so I want to at least gain back some flesh so people don't continue to ask me, are you sick? What's wrong with you? What advice can you give to people like that? What food or lifestyle can they engage in to get back some flesh?
Okay, thank you for that question. And that one would also go under the theme diabetes and well-being for this year under the IDFR option. The well-being, when people are overweight or obese and you tell them to now adopt healthy lifestyle, there's need to lose some pounds, but it is done in a healthy manner. Some people may want to do it very fast. Maybe within 2 months, I want to get back to normal and all of that. We don't tell them that. They lose this weight gradually over 1 year, over 2 years. So it is a gradual process. The one that you're talking about may be when they have developed the disease and they are passing a lot of fluid, a lot of glucose, and they are just wasting what is necessary for the body, together with some electrolytes too that are good for the body. So, but by the time they start treatment, they will go back to the normal BMI. So, and then the term skinny or thin is subjective. Maybe somebody that is obese, very big, and then the person is now overweight. People that might have seen them 6 months ago would see them as, you've lost so much weight. Whereas they are overweight, they are still going back to the normal BMI. So it is part of the education for these patients that they should not bother. Because by the time you table before them the complications that can arise from the disease, losing their sight, having their limbs amputated, having an heart attack, developing kidney failure, in which they'll be looking for somebody to donate a kidney to them. And then they place it side by side with societal acceptation or approval. Then they will be more positioned to be able to answer that question. Now I'm good. I think I'm good.
So they shouldn't bother about what people say about it.
But they should do it the right way. Just like I've said. Not that somebody will come from BMI of 35 and suddenly drop to 18. That may be cancer productive.
All right, doctor, I took this as your part. In short, 2 questions. Number one, before, like 10, 15 years ago, when we were much younger than this, we used to, when we hear it, we think it's old people's disease. Okay, because you hear, oh, it's your grandfather, it's your grandmother. But these days, we have young people presenting with all of these things that we have talked about. Is there a reason for that? That's number one. And number two, we won't talk about information, we won't talk about education without talking about hope on this program. For those that have these things, it has been confirmed, and they are listening to you this morning. And many of them, because I was going through a particular piece, and it says people living with diabetes have experienced anxiety, depression, and another mental condition because of the diabetes. What message of hope will you be telling those that have it and they are feeling somehow they don't want to come to hospital? 2 questions in one. Why are we having it in young people now? And your message of hope. I think
Thank you.
your part.
So the first one, why we're having it in young people now, is lifestyle. It's lifestyle. It's a lifestyle. It is Western lifestyle that we are adopting. Less of exercise than eating of fast food. So people are becoming bigger than their weight, obese.
Does drinking,
overweight.
smoking have anything to do with it?
Well, smoking will make the complications maybe early and more complicated or worse. So there's something we call peripheral neuropathy. For somebody that is smoking, is going to make it worse. And this is when they walk and then they feel as if they are stepping on pepper and all of that. And then some of them may not be able to feel pain, and that will predispose them to having an injury to the foot.
Young persons, basically lifestyle.
A lifestyle.
All right, because
and then if they're genetically predisposed to having it,
to eat as well.
Yes.
How about those that has been confirmed and they're anxious, they're feeling maybe this is what we end them, and they have opportunity to look at you this morning, look at the camera and tell them something?
So diabetes is not a death sentence. Once you come to the hospital, whatever it is that you are feeling,
it's this way.
Whether you're anxious, whether you're depressed, whichever thing you are experiencing, try to tell your doctor. There are specialists that can handle this. We have psychologists. Though your doctor may try to talk to you about it, try to allay your fears, try to get you to understand the disease better. But if you emphasize it, there may be need to call some other professionals like psychologists, like other people that can handle any other thing that you are feeling. But this morning, I want to put it to you that diabetes, you can live up to your 90s, 100s, if you manage your diabetes very well. So there's no need to be anxious about it. There's no need to be depressed. Just express it when you come for clinic assessment that I'm feeling depressed. Though as doctors, we should be able to also listen for the unsaid words and to be able to be sensitive to the feeling. But maybe due to pressure of work and all of that, we miss it out. You can voice it that I'm not feeling happy. At times, from the patient's disposition, the way they are seated or the way they are looking at you, you know that this individual is depressed. But there are agents to take care of this. We have, just like I said, we start from exercise, lifestyle, diet, before medications. The drugs are very costly now, and we are shouting, even advocating that taxes should be reduced. If it can't even be completely removed from anti-diabetic agents, because they buy strips to check the glucose, they buy machine, they buy a lot of things. So it's very, very expensive to manage. But if you come for regular checkups and then you are keeping records of what you are doing, and then together with lifestyle, those ones are cheaper to do, the exercise and the food. And so the medications may not be that many. So I want to tell you, there's nothing to be anxious about. There's nothing to be depressed about. We have what we call the Diabetes Association of Nigeria, which is a support group that one can belong to, in which you see people of going through the same circumstances and situation that you have, and you can rub minds with them.
Would like to thank you, especially Dr. Adebimpe Yusuf. Dr. Yusuf is a consultant endocrinologist with the University of Osun Teaching Hospital. Thank you so much for your time this morning,
Thank you,
for
ma'am.
educating us and giving us the information we need about diabetes. And thank you for the job that you're doing too.
Thank you.
Thank you very much.
All right, that's the show this morning, people.
Right.
Thank you for being a part of our world today and for this week. We appreciate you greatly. You can watch a recap of this show from on our YouTube channel at Western Spring TV. Connect with us on our Facebook, Instagram, and X at Western Spring Television. My name is Evelyn Ohiolei. Stay tuned for Spring Trends coming right after this broadcast.
All right, as they say, I said it earlier, and I'll round off it with it as well. No matter your achievement, no matter your vision and your goal, please take care of yourself. You know why? Health is wealth. Femi is my name, and at this juncture, we sign off for this week. God willing, we return on Monday for another fresh edition of this program. God bless Nigeria. Bye.